Yeah.
Okay, we're going to get started. I have 2 sessions this year. Last year I had 3, and Dr. Shell wants me to cover everything that I covered last year. So what I'm going to do is I'm going to start, and I will probably go past 6:45, but the rest of it will be on podcast. So we're going to cover many, many topics today, including uteroplacental perfusion. So we're going to start out with a question. So which of the following is most likely to decrease uterine blood flow? A, put up your hands, A, which is epidural bupivacaine with epi, B, terbutaline, C, magnesium, or D, paracervical block. So the answer is actually going to be D, and that's part of why you've probably never seen a paracervical block done for labor analgesia, even though it can give good analgesia for the first stage of labor. So a bit about uterine blood flow. The uterus is one of those organs that is not capable of autoregulation, so your uterine perfusion is going to be dependent on an adequate driving pressure, essentially your maternal blood pressure. Having low uterine venous pressure and low uterine vascular resistance. Those are the important parameters in terms of maintaining adequate uterine perfusion. So what's going to decrease uteroplacental perfusion? These are questions that you may see on the boards. And low uterine artery pressure, so if mom's hypotensive, obviously. Increased uterine venous pressure, and so most commonly this will occur with vena cava compressions if you have a gravid woman flat on her back, if she's having contractions, especially if she has uterine hypertonus, and that's why when you're on labor and delivery and they start having a concerning tracing, they may turn off the Pitocin if they think she's hypertonic, and the Valsalva maneuver may also contribute to that, which you can see during the second stage when the woman's pushing. Increased uterine vascular resistance will also decrease your perfusion, so that would be vasoconstrictors, but not like 1 to 200,000 epidural epinephrine. That was one of your potential answers in that question that I just asked you. A high concentration of local anesthetic. That is a major reason why the paracervical block was the correct answer, because when you're injecting that local in that area, there's going to be a high concentration of local anesthetic in the area of the uterus. Preeclampsia increases your uterine vascular resistance, so this is one of the reasons why we're more likely to see problems with fetal heart tones with preeclamptic patients, and diabetics also have increased uterine vascular resistance. Another question that gets asked is choice of vasopressor. So, ephedrine and phenylephrine are the 2 vasopressors used most commonly in obstetrics. Now, ephedrine, as you know from your pharmacology, has both alpha and beta effects, and actually would have less of an increase in uterine vascular resistance compared to phenylephrine, which is a pure alpha vasopressor. And in fact, many years ago, it was the vasopressor of choice in OB. Phenylephrine, though, has become the choice that's the first choice in most patients now, even though it has a pure alpha effect, and that's the reason why in the past it was avoided in OB, because they thought it would, worsen your uterine vascular resistance. But many studies over the last 10 or 12 years have now shown that actually cord pHs of infants whose mothers received phenylephrine to treat maternal hypotension were higher than they were in women whose moms receive ephedrine. This seems to be actually an effect on the fetal side, and that there's much greater placental transfer of ephedrine than phenylephrine, and that ephedrine on the fetal side essentially revs up the baby's metabolism, and that's what contributes to that lower cord pH. So now generally your vasopressor of choice will be phenylephrine, but if you do have a mother who will not tolerate for some sort of cardiac reason phenylephrine, then you would use ephedrine. And if you had a mother who was extremely bradycardic, you would use ephedrine rather than phenylephrine. Maternal-fetal drug transfer is another topic that's been covered on a fairly regular basis when you're taking your ITE. And so factors that affect placental transfer, one is the maternal concentration of the drug. The higher the maternal concentration, the greater the maternal-fetal drug transfer. The drug diffusion constant for that particular substance, and that is going to be increased by being small. So particles that have a low molecular weight is going to have greater placental transfer to the fetus. Low protein binding, because only the unbound drug crosses, so drugs that are highly protein bound are going to have significantly less transfer. High lipid solubility, so those that are water soluble are going to have much lower transfer. And then the degree of ionization, because just like only unprotein bound substances can cross, only those substances that are unionized can cross. So those are the major factors that are going to affect your maternal-fetal drug transfer from that standpoint. Other factors that are going to affect placental transfer is that you can have placental binding of substances within the placenta, and if you have a high degree of placental binding, you'll have less drug transfer. Placental metabolism, the placenta is a very active organ in and of itself, and so it will use up some of what comes to it. And then finally, any factors that alter your placental perfusion. So if you have aortic compression, although that's generally not considered to be good, it will decrease the amount of any particular drug you're giving to mom crossing over to the baby. Hypovolemia, vasoconstrictors, all factors that will alter placental perfusion and can affect the degree of maternal-fetal drug transfer that occurs. Factors that will affect on the fetal side, the drug concentration seen by the fetus. Metabolism. So the thing you need to keep in mind is that lots of the pathways that metabolize various substances are immature within the fetus. And so you will see a fetus with significantly higher levels than you would see in an adult. Fetal protein binding, there's lower protein binding capacity in the fetus compared to the mother. So drugs that are generally highly protein bound in the mother, if the amount that crosses over to the fetus, you're now going to see a higher concentration on the fetal side in terms of the free drug levels because there's less ability for protein binding. And then fetal pH is another significant factor in terms of affecting drug concentration. So here's another question. You have a patient who is receiving epidural labral analgesia. She's taken to the OR for emergent C-section due to fetal bradycardia, and her epidural needs to be dosed to avoid general anesthesia. So which local anesthetic are you going to use? A, anyone? B, anyone? C, anyone? So everyone says chlorprocaine, which is correct. And the reason for that is related to the ionization aspect, fetal pH. So concern in acidotic, if you have a baby that's having fetal distress, signs of an abnormal fetal heart tracing, you generally should assume that that fetus is probably acidotic. And so what you're concerned about with most of your local anesthetics in that setting is what we refer to as ion trapping, which means that the local anesthetic crosses over to the fetal side. When it crosses to the fetus, it becomes ionized in that acidotic environment. And then the ionized form, as we said, cannot cross over either way. And so you get an accumulation on the maternal side. And so you can end up, if you go on to delivery, in an acidotic fetus having used bupivacaine or lidocaine, you're more likely to see essentially a floppy baby at delivery. Chlorprocaine is the drug of choice in these settings because ion trapping is generally not an issue with this drug because, number one, it has such a short maternal half-life that there's very minimal drug transfer of chlorprocaine to the fetus. So you don't worry about that ion trapping, and that is a major reason why would you use it in the setting of a distressed fetus. So the least amount of placental transfer will occur with which of the following anesthetic drugs? A, isoflurane. B, sufentanil. C, succinylcholine. Okay, most people are putting up their hands. D, ketamine. And the answer is C, succinylcholine, and the reason for that, an easy thing to remember, is that all of your neuromuscular blocking agents are big molecules, and we talked about size as one of the factors that affects placental transfer, so you have very minimal transfer of your neuromuscular blocking agents. Some other frequently asked questions, drugs that don't cross the placenta in significant amounts. So your neuromuscular blocking drugs, as I just said, due to their high molecular weight as well as their ionization, so you rarely are going to see the neuromuscular blocking drugs that you give to mom affecting neonatal muscle tone. Heparin is a very large water-soluble molecule, so you don't see placental transfer with that, and that's why when you have a pregnant woman, say, who's being anticoagulated with Coumadin, they will generally switch her over to heparin or Lovenox because of that. And then finally, insulin is another large molecule with no placental transfer, and in terms of diabetes, this is an issue because babies will see if mom's hyperglycemic. They will see all that glucose that will easily cross over, and they will make more insulin for that. But then when but they won't get any of mom's insulin levels transferred over. So then when they're delivered, they still have the high insulin levels that they've developed as a result of seeing that high glucose concentration from mom being hyperglycemic, but now you've taken away all that glucose, and that's why we get concerned about hypoglycemia in babies whose moms were diabetic. Maternal-fetal distribution of bupivacaine is another topic to be aware of. In terms of protein binding, this is one of the drugs that's very highly protein bound, and it also, the drug has a high pKa, so these factors limit its transfer to the fetus. However, once whatever bupivacaine is able to cross over to the fetal side, because of the decreased protein binding, this leads to fetal concentrations of the free drug that will actually equilibrate with the maternal concentration. So the thing to remember with bupivacaine is that your total fetal concentration is going to be less than your total maternal concentration, but the concentration of your active drug is pretty quickly going to equilibrate between maternal and fetal side. What about placental transfer of anticholinergics, another common topic? It directly correlates with the ability to cross the blood-brain barrier. So, for instance, atropine and scopolamine both easily cross, and so they can affect fetal heart rate. Glycopyrrolate minimally crosses the placenta, so it doesn't have any significant effect on fetal heart rate. So just kind of remember in your brain, if it's a drug that I think of that it crosses the blood-brain barrier, then it's also crossing the placenta, and I'm going to see heart rate effects in the fetus. Glycopyrrolate doesn't, so I don't see significant fetal heart rate effects. What about oxygen transport between the mother and the baby? So placental oxygen transport occurs via diffusion. So it's going to be determined by the difference in PO2 between mom and fetus. And that is going to drive oxygen delivery over to the fetal side. Other things to keep in mind in terms of effects on maternal-fetal oxygen transport is the Bohr effect. And this refers to the fact that at the same time that you have oxygen being transported from maternal to fetal side, you're also having fetal to maternal transfer of carbon dioxide, which makes your maternal blood more acidic and your fetal blood more alkalotic. As a result, that leads to a rightward shift of the maternal oxyhemoglobin dissociation curve and a left shift of the fetal curve, and that in addition favors unloading of oxygen to the fetus. So one thing to remember is that pretty much every factor is going to favor oxygen delivery from the maternal side to the fetal side. In terms of fetal oxygenation, despite the fact that you have all this oxygen wanting to go over to the fetal side, if you look at a core pH, you'll notice your fetal PO2 never gets over about 50 to 60 millimeters mercury. There's a couple of reasons for that. We talked about maternal-fetal transfer of various substances, one of those being consumption by the placenta. And so the placenta is a very active organ. It has a high rate of oxygen consumption. So a lot of that oxygen that's going from the maternal side over actually gets used up by the placenta. And the other reason that your fetal PO2 is never going to be higher than 50 to 60 is that the fetal arterial blood is actually a mixture of oxygenated umbilical venous blood and deoxygenated blood coming from the fetus's IVC. So highest PO2 you're going to see is about 50 to 60. What about the effects of maternal PaO2 on fetal oxygenation? So in a normal fetal PaO2, an increase in your maternal FiO2 is going to have only a minimal effect on your fetal PaO2. But you would say, but oftentimes if we have a disturbing fetal tracing, one of the first things the labor and delivery nurse does is that she puts oxygen on mom. And the reason for that is if you have a concerned tracing, you're concerned about the possibility that there's fetal hypoxia going on. And in that situation, when you have a decreased fetal PaO2, there will be an increase in maternal FiO2 can be beneficial because at that point you're at a steep part of the fetal oxyhemoglobin dissociation curve. So when you have a distressed fetus, the addition of additional increasing mom's FiO2 and then ultimately her PaO2 will have an effect on improving oxygenation to the fetus. But on the other hand, if you have a normal fetus plopping oxygen on mom and increasing her PaO2 isn't going to significantly affect your fetal PaO2. Now we're going to move on. We talked about drug transfer, oxygen transfer. Now we're going to go on to fetal heart rate patterns. So, which statement about fetal heart rate patterns is most likely true? A, that early decelerations indicate fetal hypoxia. B, that maternal drug administration does not influence fetal heart rate. C, that beat-to-beat variability is an insensitive indicator. Or D, that a sustained fetal heart rate over 180 could be indicative of fetal hypoxia. So Dr. Hernandez is shaking his head for D, and that would be correct. And what's tricky sometimes is that you need to know not only what the different types of fetal heart rate patterns are, but what causes them to be that way. So, in terms of fetal heart rate monitoring, when we look at the fetal heart rate monitor, it's a lot like looking at EKG. So the first thing that we look at is our baseline heart rate. Then the next thing we'd have to do is systematically want to look at the variability of the fetal heart rate. Third, you want to look at periodic patterns, which is, are they having accelerations, decelerations? And lastly, you need to look at the uterine activity and see how some of those changes, some of those patterns are in relation to your uterine activity. So a normal baseline fetal heart rate is generally 120 to 160. Anything over 160 is considered tachycardia. Generally less than 120 is bradycardia, although sometimes you may have a baby that has a normal lower baseline, maybe 110. As long as all the other parameters are normal, then we don't worry about that. But if there's been a significant drop, then we do. So let's look at the etiologies of some of the abnormal fetal heart rates. So etiologies of fetal tachycardia can be a variety of things. As we mentioned, it can be due to fetal hypoxia due to inadequate uteroplacental perfusion. So that can be concerning. But there are other things besides that that can also cause fetal tachycardia, which would not require you to have to quickly deliver the baby. So you need to kind of look at the situation and determine what is causing the tachycardia in this baby. So if you have a mom who's febrile or septic, that can cause fetal tachycardia. Mom's tachycardic, baby can also be tachycardic because baby also gets hot when mom is hot. Maternal thyrotoxicosis can be another cause, but most importantly, a variety of drugs that both we give and the obstetricians give can also result in fetal tachycardia. So some of the tocolytic drugs, the beta-mimetics, terbutaline, can cause fetal tachycardia. If we give ephedrine in large enough doses, if you give 5-10 milligram bolus of ephedrine, you're not going to see fetal tachycardia, but if you've over the last few minutes given a whole syringe of ephedrine, you could possibly see that. And as we mentioned earlier, a drug like atropine is also going to cause fetal tachycardia. What about fetal bradycardia? We tend to get even more concerned about this, and that is because most of the etiologies of fetal bradycardia are quite concerning. So it can be acute fetal asphyxia, you can have an acidotic fetus. Local anesthetic toxicity from a paracervical block, as we mentioned, that can cause fetal bradycardia. And it's actually well known for that it's associated with fetal bradycardia. That's why, although it can provide analgesia during labor, I've never seen it used in all of my years to manage labor analgesia. Maternal beta blockers, especially the pure beta blockers, can cause fetal bradycardia. There have been case reports of that. It's unusual, but it can happen. And then another cause of bradycardia can be congenital heart block. Now, the next thing after you've looked at your actual baseline fetal heart rate, then we're going to go on to fetal heart rate variability. So the most important thing is your beat-to-beat variability, which is the most sensitive indicator of fetal well-being. So that is why the obstetricians are always looking and concerned about variability and talking about, oh, that tracing looks flat, I'm concerned. You can also look at long-term variability, which is over a few minutes, and that's another indicator of fetal well-being, but it's not as sensitive. So really the most important one is beat-to-beat variability, which can only really be assessed with an internal fetal scalp electrode. External monitoring will not allow you to really accurately assess beat-to-beat variability. And just an example of beat-to-beat variability that would be normal here, this would be a good tracing. If it was very flat, you'd be concerned about that. What are some reasons for decreased beat-to-beat variability? Again, you have to differentiate. So fetal hypoxia and acidosis are the major concern, that could be the cause for your decreased variability. However, it can also be due to fetal sleep cycles. So sometimes the obstetricians may do something to try to stimulate the baby to see if the variability improves. But most importantly, you need to realize that your various maternal drugs, including lots of drugs that we give, like opioids, barbiturates, volatile anesthetics, can all affect your beat-to-beat variability. So for instance, if you are doing a general anesthetic for a non-obstetric surgery in a pregnant woman and you are doing fetal heart rate monitoring, you shouldn't get concerned that your variability is decreased, because it's going to be decreased. That's not part of your monitoring that you really can assess when you have a woman that's anesthetized. In terms of periodic patterns, accelerations are defined as a fetal heart rate increase of at least 15 beats per minute, either with fetal movement or with uterine contraction. That's a sign. That's a good sign that baby has an intact CNS. Decelerations, there's early decelerations, which essentially the onset and then the peak all occur along with the contraction. And generally these are not deep decelerations. You generally, with an early deceleration, will not see the fetal heart rate drop below 100 beats per minute. Variable decelerations, easy to remember what they look like, variable. So they are different with each contraction. They can vary in shape, in how long they last, the peak, how far down they go. Commonly, though, you will see a significant drop in fetal heart rate below 100 with variables. And then lastly are late decelerations. And the key with these is that the deceleration occurs, its onset occurs after the peak of the contraction. And again, late decelerations are usually not particularly deep. So just an example of an early deceleration, variable decelerations, you can see it's a little bit different with each contraction, and then late decelerations, which can be kind of, as I said, they're not particularly deep. So you may not realize that that's a very concerning tracing, because as we're going to go on to talk about what are the etiologies of these various decelerations. So early decelerations generally result from a vagal reflex on the side of the fetus due to head compression during contractions. They're not concerning. They don't require any sort of treatment. You just realize that they are there. Variable decelerations are also a vagal response. So I've seen that as a question. What's the etiology? And the answer is vagal response, both for early decelerations and variable decelerations. The vast majority of your vagal decelerations, though, result from umbilical cord compression. So they can be more concerning, especially if this is happening with every contraction, because that is interfering with uteroplacental perfusion as a result of that cord compression. Occasionally, you can also see variable decelerations occur in late labor due to intense dural stimulation as the head is compressed as it traverses through the birth canal. So if you start to see variable decelerations all of a sudden and the tracing was looking fine before, it may be that the baby's getting ready to deliver. That's oftentimes a reason to ask the obstetricians to do a cervical check and make sure. So in terms of variables, as I said, if they're recurrent and they're deep and they last a long time, they don't recover very quickly, those are going to be concerning in terms of fetal status. But if they're just occasionally having variable decels, they're not particularly deep, then usually you're not going to get concerned about that. And then finally, late decelerations. The thing to remember about these is anytime you have late decelerations, even if it's a drop of just 5 or 10 beats per minute, they are concerning, because the etiology of late decelerations is inadequate uteroplacental perfusion. So if you see these, initially what you're going to do is in utero resuscitation. So late decelerations, this is when you're going to put oxygen on mom. You're going to make sure she has good left uterine displacement. You're going to check her blood pressure, treat any degree of hypotension at all with vasopressors and with fluids. Next, we're going to talk about umbilical cord blood gases. So what finding on umbilical cord blood gas analysis is most likely to be associated with an adverse neonatal outcome? Would it be an umbilical vein respiratory alkalemia, an umbilical artery respiratory acidemia? That should be acidemia, not academia, sorry. Umbilical artery mixed acidemia, or an umbilical vein respiratory acidemia. So what do you think the answer is? So the things to remember is the umbilical artery results are primarily indicative of the fetus. Umbilical vein is more of what's going on within the placenta and from the maternal side. And then acidemia, metabolic or mixed acidemia is what's concerning. A respiratory acidemia is not going to be particularly concerning in terms of affecting neonatal outcome. So these, just to show you, this is what you can expect in the way of normal umbilical vein and umbilical artery blood gases. And in terms of acidemia, how do you identify what type of acidemia? So a metabolic acidemia, your PCO2 is going to be normal, your bicarb is going to be low, your base deficit is going to be high. The same with a mix. So what you're looking for, the concerning blood gas results are those where you have a low bicarb and a high base deficit is what you're looking for. With your respiratory acidemias, you have a high PCO2 but normal bicarb and base deficit. Those are not going to adversely affect the neonate like your mixed and metabolic acidemias. So now we're going to move on to physiologic changes of pregnancy. They like to ask a lot of questions about this. Usually what I recommend is a day or so before the test, just kind of review it again because I know it can be hard to remember all these various physiologic changes of pregnancy. So, when is the cardiac output of a parturient at its highest level? A, first stage of labor. B, immediately postpartum. I see hands going up. C, second stage of labor. D, second trimester. The answer is immediately postpartum. Also cardiac. So which of the following is most likely to represent an abnormal finding in a woman at 38 weeks gestation? Left axis deviation on the EKG? No, that's actually normal. Pulmonary artery occlusion pressure of 22? Okay, right. So your central pressures should not change in pregnancy. Even though, as we talk about, you have an increase in blood volume, you also have vasodilation, so they should be normal. It's normal to see a little bit of mild tricuspid regurg if you do an echo on a normal pregnant patient, and they can also have a third heart sound. So lots of cardiac changes that normally you would think are abnormal are normal in a pregnant woman, but increased PA pressure is not normal. So in terms of cardiovascular changes of pregnancy, cardiac output increases throughout pregnancy. By the time you get to the third trimester, cardiac output has increased by about 50% above pre-pregnancy baseline. This results primarily from an increase in your stroke volume, although you also see a small increase in heart rate. And then when you get into labor, you see even greater increases. And this is why labor and delivery is a particularly crucial time in women who have underlying cardiac disease. So during active labor, 5-6 centimeters dilated, above and beyond that 50% increase that has occurred over pregnancy, you'll see another 30% increase in cardiac output. Second stage of labor, where she's now pushing, you see about a 45% increase above and beyond that 50%. And then lastly, in that immediate postpartum period where you have a large involution of the uterus, a large autotransfusion, you can see as much as another 80% rise above and beyond that 50% rise in cardiac output. So that is one of the most crucial times. Sometimes you have a patient with significant cardiac disease and you've been watching them like crazy throughout labor and they deliver and your reflex is you want to step back and say, we got through this, baby's delivered, everything's fine. But in fact, for mom, that is one of the most crucial times where she may decompensate because of that large increase in cardiac output. As I mentioned, your blood volume does increase by about 35%, primarily due to increase in plasma volume. You do see some vasodilation. SVR decreases by about 20% during pregnancy, which leads to a mild decrease in blood pressure compared to baseline before pregnancy. And as I mentioned, your central pressure should be unchanged, and any increase in central pressure is pathophysiologic. Going on, let's talk about other things that can change in the pregnant patient. So, which of the following is most likely to be decreased in a healthy parturient at 36 weeks gestation? Total red blood cell volume, tidal volume, serum creatinine. Okay, I see a lot of answers for that. Factor VII level, and the answer is serum creatinine. So let's review some of the other changes. In terms of respiratory changes, Another big important system for us as anesthesiologists. Minute ventilation increases by up to 50% at term. Again, increased primarily by tidal volume. So both with your minute ventilation and your cardiac output, it's primarily the volume part of that equation that increases during pregnancy. But you may see some small increases in respiratory rate also. In terms of your lung volumes and capacities, you will expect to see decreases in your expiratory reserve volume and your residual volumes. You'll see a slight increase in your inspiratory reserve volume. One of the most important things to understand is to do those decreases in ERV and RV, you will see a decrease in your functional residual capacity of about 20%. And this is in an upright pregnant woman. When you lie her down supine, you will see further decreases in FRC. And if she is morbidly obese, you will see even further decreases in FRC. Your total lung capacity, though, and your vital capacity are unchanged in pregnancy. Oxygen consumption increases significantly, makes sense, during pregnancy by about 20%, and then during labor you can see as much as a 100% increase in oxygen consumption. Another thing to remember is the oxyhemoglobin dissociation curve shifts to the right on the maternal side. Easy way to remember is, if you can remember what causes shifts, is always to realize that, physiologically, pregnancy is trying to help improve oxygen delivery to the baby. So anything that's going to improve oxygen delivery to the baby, when you're thinking about physiologic changes, you're going to expect that to be the case. So rightward shift of your oxyhemoglobin dissociation curve. So we talked about all of these respiratory changes. So which of these do you think is a normal arterial blood gas in a woman who's not in labor, sitting upright at 37 weeks gestation? A, B, C, or D? So we will go on and we'll look at that. So the things you're looking at is that to know that you have, is because of that increase in minute ventilation, you should expect to have a decrease in your PaCO2. So anywhere from about 26 to 32. So you're also going to have a small respiratory alkalosis. You don't have a big time respiratory alkalosis because there's metabolic compensation, so that you have a decrease in your serum bicarb. So the gas that we showed there that had the PCO2 of 30 and the pH of 7.44 would be normal. So the thing to remember when you're looking at blood gases in pregnant women is that a normal PaCO2 is low 30s. So if you have an asthmatic and her PCO2 is 40, she's already gone beyond normalization of PCO2. She's actually starting to retain CO2. And so you need to realize that what's normal in a pregnant patient isn't what's normal in a non-pregnant patient. Okay. Well, let's see if I can get it to move some other way. So, for some reason, there we go, it finally advanced. What about GI changes? Also important to us as anesthesiologists. So, in terms of hormonal changes, that will affect essentially most of your physiologic changes of pregnancy are somehow related to hormonal changes. So in terms of GI changes, there's a significant rise in progesterone during pregnancy, and this leads to a reduction in your lower esophageal sphincter tone, which is going to put the patient at risk for aspiration. There are also mechanical changes that also will affect your GI changes. So as a result of that growing uterus, you have a cephalad displacement of the stomach. That's going to result in an increase in your intergastric pressure. It's also going to distort your GE junction, which contributes to that gastric reflux that is common in pregnancy. But the combination of all these things is, most important thing is that in pregnancy, these women are considered to be at increased risk for aspiration. Now, hematologic changes. We do have an increase in red cell mass. Sometimes people get confused because they know there's the physiologic anemia of pregnancy. Increase in red cell mass, but the reason that you see that dilution, it's a dilutional anemia because you have an even greater increase by about 45% of your plasma volume, so that leads to your dilutional anemia. So a normal hematocrit's around 35%. So again, keep in mind, if you're trying to use hematocrit to help you think, is this patient hemoconcentrated, hematocrit of 40-41 in a pregnant woman is something you might see in a preeclamptic patient who actually is intravascularly depleted. That is actually not a normal hematocrit in a pregnant patient. Also remember that pregnancy is a hypercoagulable state with most of your factors being increased, but not all of them. There's also an increase in fibrinolysis during pregnancy. Keep that in mind. But as a result of that hypercoagulable state, when you look at maternal mortality, pulmonary embolus is always one of the leading causes, usually one of the top 3 to 4, whatever study you're looking at, in terms of maternal mortality. In terms of CNS changes, the things to remember for us as anesthesiologists is that the MAC of your volatile anesthetics is decreased by about 30%. Local anesthetic requirements also are decreased, although we want to always make sure we get an adequate block, so we don't usually significantly decrease the amount of local anesthetic we use when we're doing some sort of like a peripheral nerve block in a pregnant patient. And a lot of this results from the increase in endorphin and enkephalin levels, so you have an elevated pain threshold. In terms of the local anesthetics, in vitro studies have found that the nerves are actually more sensitive to local anesthetic than in a non-pregnant patient. In terms of renal changes, this is your correct answer, was that creatinine was decreased. So you have a significant rise in GFR in pregnancy, and as a result, your creatinine clearance is increased, and a normal creatinine is about 0.5 to 0.6. So again, if you see a preeclamptic patient and you see a creatinine of 1 or 1.1, that's abnormal. That means she's got renal dysfunction as a result of her preeclampsia. Now we're going to talk briefly about tocolytics. They've asked questions about this. So the administration of terbutaline for the treatment of preterm labor is most likely associated with what? Prolongation of pregnancy of at least 1 week, maternal hypertension, maternal hypoglycemia, or fetal tachycardia. Fetal tachycardia, we actually already mentioned this. So what else can we look at in terms of tocolytic therapy? So your beta-adrenergic agents, primarily terbutaline, what will they do? Well, they do decrease uterine activity, but only transiently. So that first one, it's been shown that with pretty much all your tocolytics, at most you're going to prolong pregnancy for a couple of days, allows you to get things like antenatal steroids in, but none of your tocolytics are really particularly effective at significantly prolonging pregnancy. Your beta-adrenergic agents, terbutaline, actually cause a vasodilatation with no significant effect on uterine blood flow. They cause bronchodilation. They cause release of ADH. Adverse effects that you can see with your adrenergic agents, and this is usually the most common question I've heard of on the ITE, pulmonary edema, maternal and fetal tachycardia. Because they cause vasodilation, you can occasionally see hypotension. Hyperglycemia is a concern. You can see this in any patient, but it's especially a concern in those patients who are diabetic. You can see hypokalemia, but the thing to remember is that total potassium does not increase, and one thing to be concerned about is if you treat that hypokalemia, you can then actually get a rebound hyperkalemia. So generally it's not recommended to treat hypokalemia that's associated with terbutaline. If you, after delivery, if they've recently received terbutaline, there are increased risk for uterine atony, and then fetal tachycardia and fetal hypoglycemia. So on the side of the fetus, your concerns are tachycardia and hypoglycemia. Magnesium sulfate is usually not used anymore for tocolysis. It is still used, though, for preeclampsia, and it's used for neuroprotection of the preterm fetus. So what can you expect if mom is on magnesium? That you'll see decreased uterine activity. Does cause vasodilation, can actually increase uterine blood flow, especially in the preeclamptic patient, and it's used for seizure prophylaxis and preeclampsia. The vasodilatation, though, is generally not particularly significant. It's not long-term, so you should not be thinking of using magnesium to treat hypertension in a preeclamptic patient. The adverse effects that we can see with this is, again, just like with terbutaline, you can see pulmonary edema. you can see sedation in mom. And then as your levels get high, things that you can see is respiratory depression at levels of about 12 to 15 actually can lead to respiratory arrest when it gets even higher. And most seriously, if you get a very high increase in magnesium sulfate levels, you can see cardiac arrest. Now, if you have someone with, for instance, who's preeclamptic with abnormal renal function, you can see an increase in your magnesium level. But these levels that are going to cause something like respiratory arrest or cardiac arrest are usually going to be iatrogenic, that someone gave the wrong dose of magnesium. The other thing to remember as anesthesiologists is that magnesium does have an effect at the neuromuscular junction, so that it does potentiate all of your neuromuscular blocking agents. Calcium channel blockers are another commonly used tocolytic. They tend to have more specific effects on the myometrium and have less effect on cardiac conduction and serum electrolytes, so generally you see less adverse events with nifedipine, and they seem to be equally effective, so they're being used more and more over beta agonists or magnesium. Hypotension is the most common side effect that you're going to see with your calcium channel blockers. Rare but life-threatening with an IV bolus is that you could see pulmonary edema and myocardial infarction, but not to the effect that you see it in some older patients with significant comorbidities. So we're going to talk a little bit about labor pain, and like I said, as you have to leave, that's fine. I have about 10 slides or more left to go through. A woman in active labor at 5 centimeters dilation is having pain with each contraction. Which of the following is most likely responsible for her pain when she's 5 centimeters dilated? A, stretching of the vagina. B, active contraction of the uterine fundus. C, pressure on the perineum. Or D, passive stretching of the cervix. So it's actually D. The fundus in pregnancy doesn't have a lot of nerve fibers. So although we always talk about the contractions being painful, it's in association with the contractions, but it's actually the stretching and dilation of that cervix that actually causes the pain. Now, which of the following anesthetic techniques is least likely to provide adequate analgesia for the first stage of labor? Combined spinal epidural, lumbar sympathetic block, paracervical block, or pudendo block? Pudendo. So CSCs we do all the time. There's rare that lumbar sympathetic blocks are done, but they have been done for labor analgesia, actually been shown to maybe make labor progress more quickly. Paracervical block, as I mentioned, can be used for the first stage of labor, but we don't do it because of its association with bradycardia. Pudendal nerve block can be used for the second stage of labor. Another question, when compared to IV opioids, epidural labor analgesia is most likely associated with which of the following? An increased incidence of C-section, a shorter duration of labor, an increased incidence of maternal fever, or a decreased need for oxytocin augmentation? So the answer is actually C. A lot of people don't realize this, but there's clearly several studies now that have shown, not necessarily causation, but have shown an association between epidural analgesia and increase in maternal temperature. Studies have not shown an increase in C-section or an effect on duration of labor, but if anything, in terms of oxytocin augmentation, again, there are studies showing an association between needing more oxytocin augmentation in women who have epidurals in place. So in terms of labor analgesia, you need to understand the physiology of it. So the first stage of labor is caused by visceral pain due to that cervical dilation and the distension of the lower urine segment. The pain pathways for that first stage of labor, the visceral afferents for the uterus and cervix accompany the sympathetic nerves from T10 to L1. So early in labor, you need a block that extends from T10 to L1 to have adequate analgesia. Now, when you get into the second stage of labor, in addition to that visceral pain, you also now have the somatic pain that results from the stretching of the perineum as the fetal head descends down through the birth canal. That somatic pain is results from nerve fibers in the pudendal nerve, and that pudendal nerve is made up of the S2 through S4 nerve roots. So by the time you get later into labor, you need a block that extends from T10 down to S4 to get adequate analgesia. We don't have a lot of time, but this just sort of shows you, because there have been questions asking you specifically what techniques will treat which parts of labor pain. And so you can just take a look at this at your leisure in terms of which different blocks are effective for the first stage, second stage of labor. Paracervical block, as I mentioned, we generally don't perform because of its risk of fetal bradycardia. Among all the regional techniques that we can consider using, you're going to see the highest maternal serum levels of local anesthetic with a paracervical block. Adverse effects of epidural analgesia include, as we know, hypotension, prolongation of labor. But this is minimal. It's primarily the second stage by about 15 minutes, and within the first stage over many hours. Some studies show no prolongation of the first stage of labor. Others have reported, less than an hour in the prolongation. But it can cause a mild prolongation of labor. But the most important thing, and this has been on the boards before, is that there is an association with increased maternal temperature. The verdict's still out as to the etiology, but we know that there is that association. And then the last couple of slides are on non-obstetric surgery during pregnancy. So which of the following recommendations best reflects the ASA statement on non-obstetric surgery? If the fetus is pre-viable, no assessment of fetal heart rate is recommended. If it's viable, continuous intra-op fetal heart rate must be performed. If possible, surgery should be performed in the second trimester. I see people putting their hands up, which is correct. Midazolam should be avoided due to teratogenic effects. So the answer is C. So in terms of even pre-viable, usually before you do surgery, you want to do fetal heart rate tones just to make sure you have an alive fetus before you start. In terms of non-obstetric surgery during pregnancy, you need to still remember that these patients are pregnant and they have those physiologic changes of pregnancy. There's still aspiration risk, still should do left uterine displacement. Other things to think about is the safety of the drugs from the standpoint of the fetus. Most importantly, though, is that your goal in terms of the fetal side of obviously do what's best for mom, but you want to do what you can to maintain uteroplacental perfusion and fetal oxygenation, and we also sometimes talk about preventing premature labor. So in terms of teratogenicity, essentially the only thing to know about is that chronic use of Valium in patients with psychiatric disorders, there has been studies that have shown an association with fetal anomalies. As a result, all benzodiazepines are classified as Class D drugs. But there's not been any reports of, a small dose for anxiolysis in a pregnant woman of midazolam having any adverse effects. So my bottom line is, if I need to use it, I will use it. For medical legal reasons, if I don't need it, I won't just give it just to give it. Nitrous oxide is controversial. There's been some data suggesting increased fetal loss, but there are actually no good studies out there that have shown an association between nitrous oxide and teratogenicity or increased fetal loss. So again, if I need to use it, I will. Essentially, the bottom line is there's no specific technique or drug that's been shown to improve fetal outcome or to make fetal outcome worse. Regional anesthesia is often preferred, mostly because it avoids the risks of general anesthesia to the mom, but also just it certainly makes sense to minimize drug exposure to the fetus, and you can do that more with regional than with general. Things to keep in mind, like I said, at 20 weeks and beyond, there can be some component of aortic cable compression. So you want to have some left uterine displacement after 20 weeks. You want to make sure you don't let mom get hypercapnic, because that can lead to fetal acidosis. But you also want to make sure that you don't hyperventilate, because sometimes we tend to do that in the operating room. But if you have maternal hyperventilation, that can lead to a maternal alkalosis, which will also cause uterine artery vasoconstriction and can adversely affect uteroplacental perfusion. In terms of fetal heart rate tracings, as I mentioned before, many of our anesthetic drugs are going to decrease or eliminate variability. So if you are doing intraoperative fetal heart rate monitoring during a surgery, the only thing you can look at really is assess your baseline. You should still have a normal baseline if things are okay in utero, and the absence or presence of deceleration. So if you see decelerations, that's concerning, but you cannot assess variability. There is an increased incidence of preterm delivery in patients undergoing surgery. We don't know really what the etiology of that is, but we know that the greatest risk occurs during the 3rd trimester, and that's part of the reason why they say 2nd trimester is the best time to do surgery, because in 1st trimester you're more concerned about organogenesis and the possible effect of any of our drugs on that, even though there's no studies to show that they adversely affect it. Makes sense to avoid it. 3rd trimester, you're much more likely to precipitate preterm labor, so that's why 2nd trimester is the best time to do surgery, if you can do it. The reality is most surgeries you're doing in pregnancy are being done because they have to be done and you can't really time it. Surgery in the pelvis or the abdomen are also high risk for preterm labor, and these are the patients where you might talk to the obstetricians about should we be doing something prophylactically to try to prevent preterm labor. Anesthesia for cerclage, I guess, is our last slide. It's usually performed with neuraxial anesthesia. When you're doing a cerclage, you need a level that extends from T10 to S4 because when they're pulling on the cervix, that's the innervation to the uterus, so that's T10 to L1, but they're also manipulating within the perineum, so you need that. And we generally will avoid sedative or anxiolytic drugs for the same reason, that we don't want to have any cause for adverse effects on the fetus. So that was very brief about non-obstetric surgery, but that's all I could talk about in like 51 minutes. So you might want to review that a little bit more before you have your fun this weekend. Thank you.